Good morning, dear students. Let me introduce myself first. My name is Irina Evgenievna Sapozhnikova. I am an associate professor at the Department of Hospital Therapy at Kirov State Medical University. I am an endocrinologist. I am going to give you lectures on the module endocrinology. Due to the fact that the time of the lectures coincides with the time of my other classes, the lectures have been recorded. The slide shows the plan of the lectures on the module endocrinology. The plan of the lectures includes classification, pathogenesis, and diagnosis of diabetes mellitus, treatment for diabetes mellitus, complications of diabetes mellitus, as well as diseases of thyroid gland, pituitary gland, and adrenal glands are to be discussed within the module. I hope our work will be productive and useful for your career. According with leading Russian endocrinologists, endocrinology is a field of medicine that studies processes of biosynthesis and mechanisms of hormonal activity, etiology, pathogenesis, and clinical manifestations of both endocrine diseases and endocrine system disorders in other pathologies. In terms of general biology, endocrinology is the science studying the humoral integrative system of the body. The glands of the endocrine system include the pituitary gland and hypothalamus, the thyroid glands, the parathyroid glands, the adrenal cortex and medulla, the endocrine part of the pancreas, the endocrine system of the gastrointestinal tract, the sex glands, testes in men and ovaries in women. The relevance of studying the discipline endocrinology, the relevance of studying the discipline model endocrinology. Endocrinology is one of the most rapidly developing areas of medicine. Every 5 Nobel Prizes in medicine has been awarded for research in the field of endocrinology. Endocrine diseases are widespread all over the world. The most common ones are diabetes and thyroid disease. Diabetes mellitus is one of the most common and socially significant therapeutic diseases. The lecture I am going to give you is on diabetes mellitus. The mechanisms of how diabetes mellitus develops are associated with insulin, a hormone in the endocrine part of the pancreas. The slide shows the location of the pancreas. Here is pancreas. According to Russian guidelines, the definition of diabetes mellitus is: diabetes mellitus is a group of metabolic conditions characterized by chronic hyperglycemia, which is the result of impaired insulin secretion, insulin activity, or both. Chronic hyperglycemia in diabetes mellitus is accompanied by damage, dysfunction, and sudden failure of various organs, especially eyes, kidneys, nerves, blood vessels, and the heart. The main manifestation of diabetes mellitus is the presence of hyperglycemia, elevated blood glucose levels. Hyperglycemia in diabetes mellitus is chronic, but is not associated with any acute disease or condition. The causes of hyperglycemia in diabetes mellitus are different depending on the causes and mechanisms of hyperglycemia. Different types of diabetes mellitus are distinguished. Diabetes mellitus is a medical and social problem. 1 in 2 patients with diabetes mellitus type 2 is not aware of the presence of this disease. According to International Diabetes Federation, there are over 476 million adults living with diabetes worldwide. The main symptoms of diabetes mellitus: polyuria, increased volume of urine; nocturia, nighttime urination; polydipsia, increased fluid intake; thirst, dry mouth; polyphagia, increased appetite; skin itching, genital itching; furunculosis, ovipustular skin diseases; and increasing the frequency of infections. Classification of diabetes mellitus: type 1 diabetes, type 2 diabetes, specific types of diabetes due to other causes, monogenic syndromes, diseases of an exocrine pancreas, and other, and gestational diabetes mellitus. The main types of diabetes are type 1 and type 2 diabetes mellitus. Diabetes can be classified into the following general categories: type 1 diabetes, due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency; type 2 diabetes, due to a non-autoimmune progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance and metabolic syndrome. Type 1 diabetes mellitus is an organ-specific autoimmune disease leading to destruction of insulin-producing beta cells manifested by absolute insulin deficiency. Diabetes mellitus 1 accounts for 5 to 10% of diabetes mellitus and is due to cell-mediated autoimmune destruction of the pancreatic beta cells. Patients with diabetes mellitus 1 have a syndrome of absolute insulin deficiency, which is a crucial decrease or lack of insulin production in pancreatic beta cells. Autoimmune markers include autoantibodies, different autoantibodies. Stage 1 of type 1 diabetes mellitus is defined by the presence of 2 or more of these autoimmune markers. The disease has strong HLA associations with linkage to the DQB1 and DRB1 haplotypes. Specific alleles in these genes can be either predisposing or protective. Autoimmune destruction of beta cells has multiple genetic factors and is also related to environmental factors which are still poorly defined. In typical cases, the disease occurs in the childhood or adolescence. In the debut of diabetes mellitus 1, there is a vivid clinical picture. The typical symptoms of hyperglycemia and rapid progression of the symptoms. Children and adolescents often present with diabetic ketoacidosis as the first manifestation of the disease. Achieving the goals of treatments allows to enjoy a longer life and a better quality of life for patients via reducing the risk of developing late vascular complications. The slide shows the diagram of pathogenesis of diabetes mellitus 1. Here is the pathogenesis of diabetes mellitus 1. Type 2 diabetes mellitus. Diabetes mellitus 2 is a chronic disease manifest by impaired carbohydrate metabolism with developing hyperglycemia due to insulin resistance and secretory dysfunction of pancreatic beta cells, lipid metabolism with developing atherosclerosis. Patients with diabetes mellitus 2 have a syndrome of relative insulin deficiency, decrease in insulin sensitivity of target tissues, impaired insulin secretion. Type 2 diabetes accounts for 90 to 95% of all diabetes cases. This form refers to individuals who have relative insulin deficiency and have peripheral insulin resistance. At least initially, and often throughout their lifetime, these individuals may not need insulin treatment to survive. The main factors in the pathogenesis of diabetes mellitus 2. We see the disease has a multifactorial pathogenesis. The main factors in the pathogenesis of diabetes mellitus 2 are insulin resistance, decrease in insulin-mediated glucose utilization by tissues, impaired insulin secretion, secretory dysfunction of pancreatic beta cells, excessive production of glucose by the liver, impaired incretins secretion. Incretins are hormones synthesized in the gastrointestinal tract that regulate insulin secretion. And next factor is increased reabsorption of glucose in the renal tubules. The slide shows insulin sensitivity tissues. The insulin sensitivity tissues are liver, muscles, fat tissue. When sensitivity to insulin with tissue, the insulin sensitivity tissues decreases, the glucose utilization is impaired. The slide shows the cell of insulin sensitive tissues Hayes with insulin receptor Hayes. In most cases, insulin resistance develops at the post-receptor level, with cascades. The slide shows abdominal obesity. Abdominal obesity is a clinical marker of peripheral insulin resistance, Hayes, abdominal obesity. Impaired insulin secretion at diabetes mellitus 2. Normal insulin secretion is biphasic. In diabetes mellitus 2, the first phase is decrease, and when a drop out of the first phase of insulin secretion. The early phase is very important for normal utilizing glycemia and maintenance of normal blood glucose levels. The second phase of secretion is preserved, but also decreases with some time. The slide shows the secretion of insulin in a healthy person. We see two phases of secretion. First phase, second phase. We see two phases of secretion with a predominance of the first phase. The incretin effect. Incretins are produced in the gastrointestinal tract. These hormones stimulate secreting insulin in response to food intake. Postprandial, after eating, insulin secretion is 50 to 70% due to the incretin effect, The slide shows a diagram of insulin secretion in a healthy person, and in a person with diabetes mellitus 2, We see in healthy people, insulin secretion increases much more significantly after than intravenously. Prandial, intravenously. This is due to certain substances in the gastrointestinal tract, which additionally stimulate insulin secretion, which is incretins. In a patient with diabetes mellitus 2, taking glucose orally, insulin secretion is significantly lower than a healthy people. Orally glucose taking, intravenously. This fact is associated with a decreased secretion in incretins. People with type 2 diabetes mellitus may have insulin levels that appear normal or elevate, yet the failure to normalize blood glucose reflects a relative defect in glucose stimulate insulin secretion. Thus, insulin secretion is detected in these individuals and insufficient to compensate for insulin resistance. Insulin resistance may improve with weight reduction, physical activity, and pharmacological treatment of hyperglycemia, but it is seldom restored to normal. The risk of developing type 2 diabetes increases with age, obesity, and lack of physical activity. The slide shows the natural dynamics of insulin resistance, insulin secretion, and glycemia, in patients with diabetes mellitus 2. We see that as the disease progresses, insulin secretion decreases, insulin resistance increases, and glycemia levels increase. The scheme illustrates the fact that diabetes mellitus 2 is a progressive disease. Therapy modifications can be necessary at a certain stage. The slide shows pathogenesis of diabetes mellitus 2 as a diagram of the so-called death octet. We see the disease has a multifactorial pathogenesis. The mechanisms of development of diabetes mellitus 2 involve insulin resistance of the liver, muscle and adipose tissue, impaired insulin secretion, impaired incretin mechanisms, increased glucose reabsorption in the kidneys, and disorders in the brain activity. In addition, pathogenesis of diabetes mellitus 2 involves violation in the synthesis of neurotransmitters in the brain, increased appetite, increased secretion of glucagon in the alpha cells on the pancreas, changes in the composition of the normal intestinal microflora, the presence of chronic inflammation, increased absorption of glucose in the gastrointestinal tract. Features of a clinical picture of diabetes mellitus 2. The disease develops at an older age than diabetes mellitus 1. A vague clinical manifestation is typical. In some cases, there may be no characteristic complaints. Diabetes mellitus 2 develops gradually, unlike diabetes mellitus 1. It does not have a clearly defined debut. This leads to delayed diagnosis of type 2 diabetes mellitus in a significant number of patients. The presence of diabetes mellitus 2 increases the risk of developing atherosclerotic cardiovascular diseases by 2 to 4 times. Atherosclerotic diseases are the main cause of death in people with diabetes mellitus 2. Most, but not all people with type 2 diabetes have been undiagnosed for many years because hyperglycemia develops gradually and at early stages in often not severe enough for patient to notice the classic diabetes symptoms caused by hyperglycemia, such as dehydration or unintentional weight loss. Even undiagnosed people with diabetes are at increased risk of developing macrovascular and microvascular complications. Type 2 diabetes occurs more frequently in individuals with prior gestational diabetes mellitus or polycystic ovary syndrome. It is also more common in people with hypertension or dyslipidemia and in certain racial subgroups. It is often associated with a strong genetic predisposition or family history in first-degree relatives. The incidence of diabetes mellitus 2 is high in the Western world, Russia, North Africa, the Middle East, and Southeast Asia. According to Russian guidelines, risk factors of diabetes mellitus 2 are age over 45 years old, overweight and obesity, family history in first-degree relatives, low physical activity, prediabetes, prior gestational diabetes mellitus, hypertension, dyslipidemia, polycystic ovary syndrome, and cardiovascular diseases. Regardless of the type of diabetes mellitus, the diagnosis of this disease is established only on the basis of laboratory criteria. For diagnosis of diabetes mellitus, it is used fasting plasma glucose, plasma glucose during oral glucose tolerance test, random plasma glucose in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, glycosylated hemoglobin. The test should be performed in a laboratory using a certified and standardized method. In accordance with the European Association for Study Diabetes and American Diabetes Association diagnostic criteria, the diagnosis of diabetes mellitus is established in the following cases. The slide shows the criteria for diagnosis of diabetes. Fasting plasma glucose equal or more 7.0 millimole per liter, or 2-hour plasma glucose equal or more 11.1 millimole per liter during oral glucose tolerance test with 75 gram anhydrous glucose dissolved in water, or glycosylated hemoglobin equal or more 6.5%. The test should be performed in a laboratory using a method that is NGCP certified and standardized to the DCCT assay, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose equal or more 11.1 millimole per liter. Here is a very important information. In the Russian Federation, diagnosing diabetes requires the detection of fasting venous plasma glycemia equal or more 7.0 millimole per liter to make a diagnosis of diabetes mellitus. In the Russian Federation, glycosylated hemoglobin is used to diagnose diabetes mellitus in combination with glycemia, fasting, randomly determined or determined during an oral glucose tolerance test with 75 grams of glucose. Diagnosis of diabetes mellitus 1 is usually based on random glycemia associated with classic symptoms of hyperglycemia or hyperglycemic crisis, typically high hyperglycemia. According to Russian clinical guidelines, the diagnosis of diabetes mellitus should be confirmed by repeat glycemic testing on subsequent days, except for cases of unducted hyperglycemia with acute metabolic decompensation or with bilious symptoms. Glycosylated hemoglobin. Glycosylated hemoglobin is a small amino fraction of total hemoglobin. Glycosylated hemoglobin binds to blood glucose non-enzymatically. The rate of this process depends on the severity of hyperglycemia. Glycosylated hemoglobin reflects the average level of glycemia over the previous 3 months. Glycosylated hemoglobin used to monitor the treatment of diabetes mellitus, to select treatment tactics for newly diagnosed diabetes mellitus 2, and together with the examination of glycemia to diagnose diabetes mellitus. The slides show the process of glycosylation hemoglobin. Here is hemoglobin and glucose, and raise glycosylated hemoglobin. Guidelines for an oral glucose tolerance test. 3 days before the examination, before oral glucose tolerance test, carbohydrates in the patient's diet should not be limited. Carbohydrate intake must be more than 150 grams per day, including easily digestible or sweet carbohydrates. 3 days before the examination, physical activity should be a habit for the patient. The last meal before the examination should take place 8 to 14 hours before the examination, before the oral glucose tolerance test, and should contain 30 to 50 grams of carbohydrates. The first blood sample must be taken on an empty stomach. After that, the patient drinks a solution containing 75 grams of the glucose dissolved in water. During the examination, patients has to sit or lie down. You shouldn't walk. Patients avoid smoking and eating. Repeat blood sampling is carried out 2 hours after taking glucose orally. Prediabetes. Prediabetes is a condition in which blood glucose levels are higher than normal but do not meet the criteria for diagnosing diabetes mellitus 2. Prediabetes is any early disorder in carbohydrate metabolism, impaired fasting glycemia, and impaired glucose tolerance. Risk factors for macrovascular complications of diabetes mellitus begin to act from the stage of prediabetes. Criteria define prediabetes according EASD and ADA are impaired fasting glucose. Fasting plasma glucose from 5.6 to 6.9 millimole per liter. Or impaired glucose tolerance. 2-hour plasma glucose during oral glucose tolerance test from 7.8 to 11.0 millimole per liter. Or glycosylated hemoglobin from 5.7 to 6.4%. In the Russian Federation, the diagnosis of impaired fasting glucose is mainly starting with a fasting venous plasma glucose level of 6.1 millimole per liter. 6.1 millimole per liter to 6.9 millimole per liter. Dear students, thank you for your attention.